Hello and welcome to this talk brought to you by Atoza. My name's Garth, and in this video we are going to be looking at the safe use of muscle relaxing drugs by the learning anesthetist. You will remember that the classic triad of anesthesia to allow for surgery is hypnosis, analgesia, and the prevention of movement. So, how can we stop patients moving during surgery? Well, there are a couple of ways we can do this. Firstly, hypnosis itself prevents a significant number of patients from moving by rendering them unconscious. Remember, at 1 Mach, 50% of the test subjects didn't show purposeful movement in response to specific noxious stimuli. But obviously 50% of the subjects did. Movement still occurs because of reflex arcs in the central nervous system in response to noxious stimuli. So we can largely prevent these reflex movements by taking away the noxious stimulus, either by giving systemic analgesia or by performing regional anesthesia. So we can prevent patients from moving by making them unconscious and by taking away their pain. And lastly, we can use muscle paralyzing drugs to prevent patients from moving. And that is the focus of this video. So why and when do we need muscle relaxants? Firstly, we often need muscle relaxants to aid airway management. Laryngoscopy and intubation can be performed without muscle paralysis, but it's far more difficult. The unparalyzed muscle tone may affect mouth opening and can affect our view on laryngoscopy. Coughing, gagging, laryngospasm, and even vomiting are far more likely during laryngoscopy without muscle paralysis. A much deeper level of anesthesia is required to blunt these responses without muscle relaxation. It may still be ineffective, or it may have significant hemodynamic effects. Muscle relaxants conveniently prevent coughing, gagging, laryngospasm, and active vomiting during airway management. Muscle relaxants also facilitate a better view on laryngoscopy and so reduce airway manipulation, trauma, and reduce pain after airway management. So that's muscle relaxants for airway management. Muscle relaxants can also be given to aid surgery, and examples here include relaxing muscles for manipulation of a joint or a broken bone during surgery, relaxing abdominal muscles to facilitate the pneumoperitoneum in laparoscopic surgery, making the surgery safer and faster. Then also preventing movement during microscopic surgery, such as neurosurgery or ophthalmic surgery. Muscle paralysis may also be required to prevent bone or muscle damage during some procedures or disease states. An example of a procedure would be electroconvulsive therapy for a major depressive episode, where we have to paralyze the patient to prevent them from having severe muscle spasms in response to the electrical current. And then an example of a disease process where we use paralysis is tetanus in the ICU setting. Tetanus results in severe muscle spasms that can result in rhabdomyolysis, and so by paralyzing the neuromuscular junction and paralyzing those muscles, we reduce those risks. And then the last indication for muscle paralysis in anesthesia is to aid in difficult ventilation scenarios. By relaxing the chest wall and the diaphragmatic muscles, it can help to reduce inflation pressures and so aids in lung protection in these difficult cases. So that covers most of the reasons why we use muscle relaxants. Let's look now at how muscle relaxant drugs work. Muscle relaxants are given intravenously so that they work quickly. They can be given intramuscularly or sublingually in an emergency situation though. There are two broad categories of muscle relaxants. Firstly, depolarizing drugs, and here the example is succinylcholine, and then non-depolarizing drugs. So firstly, looking at succinylcholine, the depolarizing muscle relaxant. After intravenous administration, the concentration of the sux in the blood is maximal. The sux circulates in the blood and diffuses into the muscles to the neuromuscular junction. At the neuromuscular junction, the sux binds to the postsynaptic nicotinic acetylcholine receptor and activates it, which causes an uncoordinated fiber contraction, and these are seen clinically as muscle fasciculations. Thereafter, the sux remains bound to the receptor, and the receptor remains in the open state. The sux block is a non-competitive block, which means that no amount of acetylcholine can displace the sux from the receptor. Succinylcholine is rapidly metabolized at the neuromuscular junction by acetylcholinesterase. As this occurs, the number of receptors occupied by the sux decreases, and slowly the muscle strength or muscle twitch returns. Full recovery of muscle strength or twitch occurs when all the succinylcholine is metabolized and is no longer at the neuromuscular junction. So from the above description, we already have a few clues as to how we will manage sux clinically. Sux causes muscle fasciculations, which will have some clinical effects. There's no reversal agent available, and offset is dependent on acetylcholinesterase. So anything that affects that enzyme will prolong the duration of action of the sux. We'll get into that again a bit later. Next, let's look at how the non-depolarizing muscle relaxants work. Again, after intravenous administration, the concentration of the non-depolarizing muscle relaxant in the blood is maximal. The drug then circulates in the blood and diffuses into the muscle to the neuromuscular junction. At the neuromuscular junction, the non-depolarizing drug binds to and blocks the nerve-muscle communication channel, which is the postsynaptic nicotinic acetylcholine receptor. The non-depolarizing muscle relaxants block the receptor in a competitive manner, which means it's the concentration of the drug versus the concentration of acetylcholine at the neuromuscular junction that determines whether the receptor is blocked or not. At high drug concentrations at the receptor, any acetylcholine that is released from the motor nerve is unable to stimulate the muscle fiber to contract. This means complete paralysis. The blood level of the non-depolarizing muscle relaxant decreases as the drug enters into the tissues, and it decreases further as the drug is metabolized in the liver, in the case of rocuronium and vecuronium, or by the plasma, in the case of atracurium or cisatracurium. As this occurs, the concentration gradient for the drug has now changed in favor of the drug leaving the neuromuscular junction and re-entering the blood circulation. Acetylcholine released at the neuromuscular junction is now slowly able to activate more and more muscle fibers, and muscle function is slowly restored. Again, from this description, we have some clues as to how this will impact us clinically. There are no fasciculations. The metabolism of the drug is dependent on the liver function and plasma enzymes. One can outcompete the drug at the neuromuscular junction by increasing the amount of acetylcholine available there. and so this is what makes reversal of the block possible. We will come back to these details a little bit later. Let's now look at how quickly muscle relaxants take to work. There are many factors that affect the speed of onset of paralysis following a muscle relaxant. Clinically, the most important factors are the dose that we give. All muscle relaxants work faster at higher doses, but higher doses come at the price of longer paralysis. Then the drug itself affects the speed of onset. Suxamethonium is faster than rocuronium, which is faster than atracurium, faster than vecuronium, faster than cisatracurium. So the take-home message, the two fastest drugs, suxamethonium and rocuronium. The route of administration affects the speed of onset. Intravenous drug is much faster than sublingual drug, which is also faster than intramuscular drug administration. Next, let's look at for how long muscle relaxants work. There are multiple factors that affect the duration of motor blockade. These include the initial dose that we give, the subsequent doses that we give, which have a much longer effect than we often expect, the temperature of the patient, the age of the patient, and other drugs that we've given to the patient, including many anesthetic drugs, and then also disease processes such as liver disease, renal disease, acid-base disturbances. In general, though, the most important factor when thinking about duration of action is the initial dose and the top-up doses. It is extremely important to understand the subtleties of drug dosing when it comes to muscle paralyzing drugs. The key points here are large doses of muscle relaxants are only needed in rapid sequence intubation scenarios. Larger doses may also be acceptable in long surgeries, but just bear in mind that sometimes even long surgeries turn out to be shorter surgeries. For example, when the surgeon starts a long procedure and then discovers that the surgery is not actually possible. And I've certainly been in that situation for some cancer surgeries where we start the operation and then we discover that the surgery is actually inoperable and it ends up being a lot shorter than what we've expected. Smaller doses of muscle relaxants will have a prolonged time to onset of relaxation, but they will still cause relaxation or paralysis. Smaller doses have the benefit that they can be titrated. When giving muscle relaxant drugs, subsequent doses after our initial dose are normally given at 25% of the usual dose, and they tend to last as long as the initial dose does. Let's look now at some specific drug doses. Looking first at the rapid sequence intubation scenario. The dose of succinylcholine is 1 milligram per kilogram total body weight, and the other drug used in rapid sequence intubations is rocuronium, and the dose here is 0.9 to 1.2 milligrams per kilogram ideal body weight. Now, this concept of ideal body weight is a little bit difficult to understand, and I never actually calculate it. I look at the patient and I estimate their ideal body weight based on their sex, their height, and their general physique, and then I calculate the rocuronium dose after that. Following a rapid sequence induction and intubation with suxamethonium, if one is going to give a non-depolarizing muscle relaxant, the dose that is required is significantly reduced, and I would recommend giving half the standard dose of the drug. Following a rapid sequence induction and intubation with rocuronium, the follow-up doses of rocuronium are again about 25% of the standard dose, not the large dose that you've just given. So this normally works out at about 5 or 10 milligram top-up doses. Let's look now at the non-rapid sequence induction and intubation scenario. So in this situation, we very seldomly use succinylcholine because of its risk and side effect profile. We tend to use non-depolarizing muscle relaxants rather. And we choose the dose based on the drug that we're using. So for rocuronium, the standard dose is 0.6 milligrams per kilogram of ideal body weight. Its onset is 90 seconds, and its duration to when we can reverse the patient is usually around 35 minutes. For vecuronium, the dose is 0.1 milligram per kilogram. The onset is 2 minutes, and the duration to time of reversal is normally about 60 minutes. For atracurium, the dose is 0.5 milligrams per kilogram. The onset is 2 minutes, and the duration to reversal is normally about 30 minutes. And then for cisatracurium, the dose is 0.1 milligram per kilogram. The onset is 5 minutes, and the duration to reversibility is about 45 minutes. Just a note on non-depolarizing muscle relaxant doses that you will see listed in the package insert or in textbooks. The doses are always actually listed at twice the effective dose, and this is to allow for faster onset of action, but it does mean prolonged duration of action. So what do I do in my practice? Well, I seldom use succinylcholine as I'm comfortable using high doses of rocuronium, and I have sugammadex available for the reversal of rocuronium. I have no problem though with the use of succinylcholine, provided there are no contraindications to its use. I never use vecuronium, as I find it far less predictable than rocuronium, especially with repeat dosing, where accumulation can occur very easily. I frequently use smaller doses than those recommended for rocuronium, and I often go as low as 0.3 milligrams per kilogram for short surgeries where paralysis or intubation is required. And I overcome the smaller doses by using a co-induction agent at intubation or a more generous dose of propofol to facilitate laryngoscopy and intubation where paralysis might not yet be complete. But there's a caveat to this. Firstly, in challenging airways, I try not to underdose my muscle paralysis because there is an increased risk of airway pain, trauma, and a failed laryngoscopy or intubation. And I don't want to get stuck in no man's land with a difficult airway where I'm struggling to ventilate the patient or to intubate the patient, and the patient is actually partially paralyzed and I don't know where I am. Again, fortunately in my situation, in these patients, I can overcome this by using a larger dose of rocuronium, and then I have sugammadex available to reverse those patients if needed. I seriously prefer the use of atracurium over cisatracurium, and this is due to its more favorable onset time and offset time. So the onset time of atracurium is 2 minutes, where the onset time of cisatracurium is 5 minutes. That's a long time to mask ventilate the patient waiting for the drug to work. And then the offset time to reversibility for atracurium is 30 minutes, and it's 45 minutes for cisatracurium. And I prefer atracurium despite the theoretical benefits of cisatracurium, which is reduced histamine release, and so a lower chance of anaphylaxis, a drop in blood pressure, bronchospasm, and those things. So I use atracurium in patients with significant liver and renal disease. Okay, so now we have an idea of how much muscle relaxant to give and how long it is likely to work. But how do we actually monitor muscle paralysis? Well, the only reliable method of monitoring depth of paralysis and recovery from paralysis is by using a nerve stimulator, and we'll get into that just now. But our clinical assessment of paralysis mustn't be totally ignored, as it does still have value. So after administration of a muscle relaxant, how do we tell that the muscle relaxant is working? Well, with succinylcholine, we wait to see the muscle fasciculations clinically to know that enough time has passed for the drug to be effective. For non-depolarizing muscle relaxants, one has to wait the required time frame, which is drug specific, which we mentioned earlier, and this ranges from about 1 minute to 5 minutes, depending on the drug you've used and the dose. When the patient is adequately paralyzed, we should notice that their airway muscles are relaxed, that their mouth opening has become easier, and that when we perform laryngoscopy, there's low tone and the vocal cords are not moving during laryngoscopy. There also shouldn't be any coughing or gagging during laryngoscopy. Then our assessment during surgery. Well, often the first signs of muscle strength returning during surgery will be a Curare cleft on the capnograph, or evidence of spontaneous breath attempts on the flow time curves or the pressure time curves. Sometimes we may see abdominal movements, especially during laparoscopic surgery, and we can also see a fluctuating inflation pressure on the laparoscopic stack, and that will be a sign that muscle tone is returning. At extubation, it's well established with multiple clinical trials that our clinical assessment of muscle strength at extubation and post-extubation is unreliable, and that we are going to miss inadequate reversal or recovery. Post-extubation, again, clinical signs of detecting a recovery or reversal of paralysis are unreliable, and again, we need to use a nerve stimulator here. But what we will see in someone who's partially paralyzed are the following. The classic picture is called the fish flapping out of water picture, and that is progressive worsening of strength, and it tends to affect the distal muscles more than the proximal muscles. So we'll see a patient that has some proximal muscle movement, but they're not able to lift their arms. They're sort of moving their torso and their shoulders, but they're not moving their legs and their arms. We'll also see hypoventilation, and the classic picture is rapid, shallow breathing, and then we might see varying degrees of patient distress with tearing, tachycardia, groaning, because the patient may be aware that he or she is still partially paralyzed while they're waking up. So the gold standard in assessing depth of muscle paralysis, recovery from muscle paralysis, or reversal of muscle paralysis is the nerve stimulator. A nerve stimulator sends an electrical impulse down a motor nerve via 2 electrodes that we place over the nerve on the skin. The artificially induced nerve impulse travels to the neuromuscular junction and stimulates the release of acetylcholine, just like a normal motor nerve impulse would do. The nerve that we use must be far away from the muscle it's stimulating, so that the electrical input doesn't directly stimulate the muscles and cloud our picture. Examples of nerves that we use: the most common one is the ulnar nerve at the wrist. We can also use the facial nerve on the side of the cheek and look at the movement of the muscles around the eye. And we can also place electrodes on the upper lateral aspect of the lower leg, just below the fibular head, and these will be over the peroneal nerve, and electrical stimulation here will cause dorsiflexion of the foot in the unparalyzed patient. Nerve stimulators have a few settings, and it's really important to understand each setting and to use it appropriately and not use them incorrectly and falsely interpret the information that you're getting. So we'll go through those settings now. The first setting is just a single twitch or a single pulse. It's got no benefit in assessing muscle paralysis during anesthesia, and we never use it. The next setting, which is the most common setting that we use, is the train of 4 count. Here the nerve stimulator delivers 4 electrical impulses to the motor nerve, and we assess the motor response to these impulses. And as I've said, this is the main assessment method for muscle relaxants. So this is what we see.
Before the scoline is administered, the 4 twitches of the train of 4 count generate 4 motor responses that are identical in their amplitude. After the scoline has been administered and the fasciculations have taken place clinically, there is no motor response to the train of 4 stimulation. There are no twitches. Then slowly, as time passes and the scoline is metabolized by acetylcholinesterase, slowly the motor responses return. And again, all 4 motor responses are identical in amplitude. Initially, the amplitude is small, but with time, the amplitude of all 4 twitches increases, and when the scoline is fully metabolized, the 4 motor twitches are back to their pre-paralysis amplitude. What we see clinically with the non-depolarizing muscle relaxants when using a nerve stimulator is that prior to administration of the muscle relaxant, the train of 4 counts will generate 4 identical motor impulses. Then after the muscle relaxing drug is given and enough time has passed for the drug to work, the train of 4 count will generate no motor response. So there will be no twitches. Then as time passes and the non-depolarizing muscle relaxant is metabolized, slowly acetylcholine from the motor nerve is able to outcompete the drug that is blocking the receptor. And what we see initially is one small twitch in response to the train of 4. And this first twitch slowly increases in amplitude as time passes until a second twitch response is achieved. And then the second twitch slowly increases in amplitude until a third twitch is achieved. And then with time, a fourth twitch is achieved. And then as time passes, all of the twitches increase in amplitude until they are back to their pre-paralysis level, and they are all identical in height. And this is when full recovery has occurred. It's essential to know, though, that when the first twitch returns on the train of 4 count, there is still 90% blockade of the acetylcholine receptors by the drug, and so 90% blockade of the motor function of that muscle. When the fourth twitch returns on the train of 4 count, there is still 75% blockade of the acetylcholine receptors at the neuromuscular junction. So one mustn't be lulled into a false sense of security that by seeing motor responses or twitches on a train of 4 counts, the patient's strength has returned. Because even with 4 twitches present, they still have 75% blockade of their function. So at this point, I want to introduce another concept when using the nerve stimulator, and that is the train of 4 ratio. Up till now, we've been talking about the train of 4 count, which is counting the number of motor twitches in response to the 4 electrical stimuli of the train of 4 count. Now we're going to talk about the train of 4 ratio. The train of 4 ratio only comes into play when we have 4 twitches present on a train of 4 count. And the ratio is looking at the amplitude of the fourth twitch relative to the first twitch. As recovery occurs, the amplitude of the fourth twitch increases, and it approaches that of the first twitch. Using a nerve stimulator, we can say that adequate recovery has taken place when the amplitude of the fourth twitch is 90% of the amplitude of the first twitch. And we call this a train of 4 ratio of 90%. And this is what we want to see when using the nerve stimulator to know that our patient is adequately recovered from their muscle paralysis or adequately reversed from their muscle paralysis.
Our reversal drugs for non-depolarizing muscle relaxants should only be administered when there are 3 twitches present on the train of 4 counts.
The reason for this is twofold. Firstly, if we give the reversal drugs neostigmine and glycopyrrolate too early, what we're going to have is a situation where they have an effect and the train of 4 count increases, but it's not going to change the amount of time required for the patient to change to a clinically reversed state. So one can give the drugs when there's 1 twitch or 2 twitches, but if we monitor this on a nerve stimulator, the time taken to get to full recovery is going to be the same. And we're just going to spend a longer period of time in the in-between zone where the patient has 2 or 3 or 4 twitches, but they're not fully recovered. The second reason, which is probably the more important reason, stems from the understanding that at clinical recovery from paralysis, there is still a significant amount of the non-depolarizing muscle relaxant drug in the system. It hasn't yet all been metabolized. And so there's a risk that this remaining drug can cause weakness or paralysis of the patient. And so when we give our reversal drugs, neostigmine and glycopyrrolate, which have a half-life of around 45 minutes, we want to give them at an appropriate time so that they cover the remaining non-depolarizing muscle relaxant drug and they significantly reduce the risk of reparalysis of the patient. So if we look at that graphically, this first graph, the red shows an approximation of what is happening to the non-depolarizing muscle relaxant drug in the body. When we give the drug, the levels in the body rapidly increase and then they decrease on an exponential curve. And then we can see the green graph shows when we give our reversal agents, and just represented here graphically, this isn't necessarily scientifically accurate. The green graph, which is the reversal agents, cover the muscle relaxants for an adequate period of time. If we depict this in a second graph, as shown here, we give our reversal agents too soon, and here the risk is that the effect of the reversal agents wears off while there is still a significant amount of non-depolarizing muscle relaxant drug in the system. And here we could have a situation where the patient goes back to the ward post-operatively and then has residual weakness or a recurrence of their weakness. Again, these graphs are not scientifically proven. It's just a graphical representation of what I'm trying to explain. Right, so now we understand the train of 4 counts and the train of 4 ratio and when to administer reversal drugs for non-depolarizing muscle relaxants. So using the train of 4 count setting on the nerve stimulator, how do we know when the patient is adequately reversed?
The patient is considered adequately reversed when the 4th twitch appears to be the same amplitude as the first twitch when we're assessing it with our naked eye, or if we have a nerve stimulator that has an accelerometer, which is a way of assessing the amplitude of each twitch, then we can say that the patient's reversal or recovery is adequate when the fourth twitch has an amplitude of at least 90% of the first twitch. And if we achieve this ratio of 90%, then we can be absolutely certain that our patient's airway muscle tone and strength is going to be returned, that their diaphragmatic muscle strength is going to be returned, and that their skeletal muscle strength is going to be returned. These patients won't have any diplopia, they won't have risks of microaspiration, and they will be strong and able to move freely in the bed. If we accept anything less than 90%, then there's a risk that our patient will have some of those symptoms. And at a train of 4 ratio below 70%, it's likely that when you wake the patient up, that patient is clinically going to appear still partially paralyzed. So we definitely need to have the ratio above 70%, but the gold standard is to have that ratio above 90% before we extubate these patients. Let's now look at the third setting on the nerve stimulator, and this is double burst stimulation. Here the nerve stimulator sends 2 electrical stimuli to the nerve in quick succession. And this is another way of assessing the adequacy of reversal or recovery. Nothing else. We don't use this test in any other situation other than to determine whether reversal or recovery is adequate. So if the 2 twitches that we see in response to the double burst appear equal in amplitude to the naked eye, then reversal should be adequate. But if the second twitch to the naked eye looks like it's a lower amplitude than the first twitch, then reversal is not adequate and we need to wait longer for the muscle relaxant to wear off or our reversal drugs to have their full effect before we wake the patient up. The fourth setting on our nerve stimulator is something called tetany and then a post-tetanic count. In this mode, the nerve stimulator delivers a prolonged electrical stimulus to the nerve. There's then a pause, and it then delivers 20 short impulses to the nerve. And this mode is only used during deep muscle paralysis, when the train of 4 count is 0. So it's a way of assessing just how deeply paralyzed our patient is. And normally this isn't a big deal. Normally if the train of 4 count is 0, we're happy with that and we know that the patient is paralyzed. But there's certain surgeries where we can tolerate no movement at all or no risk of movement. Those, for example, could be microscopic brain surgery or retinal surgery, where any small movement by the patient could disrupt the surgery in a catastrophic way. And so during these surgeries, we might want to know just how paralyzed the patient is, how close are they to having 1 twitch on the train of 4 count, and therefore the potential for movement. And so although their train of 4 count is 0, we want to see how close they are to becoming 1 twitch. And we use tetany and then a post-tetanic count to do this. And normally on a post-tetanic count, when we have about 7 twitches out of the 20 electrical impulses after the tetany, then we're close to getting our first twitch on the train of 4 ratio. And in these surgeries, we may then need to give more muscle paralysis. So for the learning anesthetist, this is not a mode that you're going to be using because you're not going to be doing these types of surgeries. A common mistake that I've seen learning doctors make is they deliver a tetanic stimulation and then immediately assess the train of 4 ratio. The tetanic stimulation is going to alter the reading on the train of 4 ratio, and it's going to get the ratio higher than what it actually is. And it's going to lull you into a false sense of security if you wake that patient up. So don't do tetany and then a train of 4 count. If you make the mistake of doing a tetanic stimulation, well then wait at least 5 minutes before repeating your train of 4 counts and getting a true accurate reading of where you are for this patient. So what do we do if we're in a situation where there is no nerve stimulator? And this might be a situation that happens in a number of hospitals, or where the nerve stimulator is being used in another theatre, or where it's recently been dropped and broken. These things happen. So firstly, in these circumstances, you need to be extra careful about your dosing of these muscle relaxing drugs. You don't want to overdose. You want your top-up doses to be small and rather give frequent top-up doses than give big doses and overdose the patient. You then also need to have some idea of the duration of action of these drugs following your dosing. So let's go through 2 examples. The first example, a rapid sequence intubation with scoline, and after about 8 minutes, the patient starts to make some spontaneous movements, and so we give a dose of rocuronium for the surgery, and we give 20 milligrams to this patient who weighs 70 kilograms. We can expect that that rocuronium dose is going to last about 20 minutes. The patient then towards the end of the surgery starts moving again and it's disrupting the surgery, so we give another 5 milligrams of rocuronium, and we expect this to last again about 10 or 15 minutes. So after the scoline has worn off, we expect that this rocuronium dosing is going to mean that we can reverse the patient after about 35 or 40 minutes. So we're in a good situation. Let's look at the second example now. So this is a non-rapid sequence induction and intubation, and we use vecuronium in this case. Here we administer 6 milligrams, and that's going to last 60 minutes. During the surgery, the patient starts to fight the ventilator a bit, and the surgeon complains, and in your haste you make an error and you give a further 2 milligrams of vecuronium. But that's going to last another 60 minutes. So this patient is going to be paralyzed for 120 minutes before we can give them reversal and before we can wake them up. So in general, our dosing needs to be very careful, but especially if we don't have a nerve stimulator. You then also need to look for signs of motor strength, which we've said are notoriously inaccurate, before you extubate the patient. So we want to see spontaneous respiration with an adequate tidal volume. We want the patient to open their eyes in a sustained manner. We want them to make purposeful movements towards the endotracheal tube. So lifting their arms up, and perhaps even when the patient lifts their arm, you try to pull it away from their mouth, and you can feel there's good muscle strength when you do that. The patient might also cough with the endotracheal tube in situ, and we want to see a good tidal volume and good muscle strength during that cough. So those are signs that the patient should be extubatable when we don't have a nerve stimulator available. But like I said, they are notoriously inaccurate because they miss things like diplopia and airway weakness, which may be unpleasant to the patient and can also lead to microaspiration and pneumonia. And then lastly, if we don't have a nerve stimulator, after extubation we need to watch the patient for features of weakness, such as rapid shallow breathing, a floppy fish picture, a poor response to squeeze my hand, patients that are unable to lift their head off the bed or that have a weak cough. And those are signs that this patient is still significantly paralyzed. So what do we do if we suspect inadequate muscle recovery or reversal? Well, we have to go into an ABCD resuscitation mindset, meaning that in the worst case scenario, we might need to support ventilation, either with bag mask ventilation or reinduction of anesthesia and securing the airway again. In less severe scenarios where the patient is breathing adequately, supplemental oxygen might be acceptable, but in this situation we need to reassure the patient what is happening and explain to them that their strength will slowly return and how we are watching them and how we're going to correct the problem. We can repeat a dose of reversal agents, so the neostigmine and glycopyrrolate, but if we do this, we have to watch very carefully for the side effects of neostigmine, bronchospasm, hypersalivation, bradycardia, and then also repeat dosing of neostigmine like this frequently causes nausea and vomiting, so we'll need to have an antiemetic ready. And then obviously we need to repeat dose the glycopyrrolate as well. And then if you're working in a setting where you have Sugamidex and you've used rocuronium, well then Sugamidex is the gold standard management in this situation. And you administer 2 milligram per kilogram IV bolus, and this will correct the paralysis within 30 to 90 seconds. And it really is quite amazing how quickly it has its effect. So we've spoken a bit about reversal of muscle relaxation or muscle paralysis. Let's actually now get into the details of how we do this. So for succinylcholine, there is no reversal drug available. Time is the only reversal agent. And then for the non-depolarizing muscle relaxants, as explained above, there's a natural decline in the effect of the muscle relaxant with time due to metabolism and excretion of the drug. It's fascinating to know that when we start to see clinical signs of movement or recovery during our anesthetic, such as abdominal muscle tension, signs of spontaneous breathing on the flow loops, there's still up to 90% receptor blockade by the drug. Also, if we're using a trainer 4 monitor, when our first twitch returns on the trainer 4 count, there's still 90% receptor blockade. And reversal of these drugs is only safe when there are at least 3 out of 4 twitches on the trainer 4 count. Non-depolarizing muscle relaxants can be reversed with neostigmine and glycopyrrolate. Neostigmine inhibits acetylcholinesterase, which means it reduces the metabolism of acetylcholine, and so it increases the amount of acetylcholine at the neuromuscular junction. And this acetylcholine can now compete with the residual non-depolarizing muscle relaxant drug for receptors. Remember, we said that these drugs cause a competitive block, so we can outcompete them by increasing the concentration or the amount of acetylcholine at the receptor. However, the extra acetylcholine can only outcompete these drugs when the drug levels have dropped to a significantly low level. Otherwise, the increased acetylcholine will only have a transient effect and then its effect will be lost. So we only give reversal drugs when the trainer 4 count is 3 out of 4. Neostigmine has many serious side effects, as it also increases acetylcholine levels at the muscarinic parasympathetic receptors. And this will cause bradycardia, increased salivation, increased respiratory secretions, bronchospasm, and increased gastric motility. And this is why we give glycopyrrolate. Glycopyrrolate is an anti-muscarinic drug, an anticholinergic drug specifically working at the muscarinic receptors, and it's to prevent these adverse effects of neostigmine. The dose of neostigmine that we give is 0.4 milligrams per kilogram, and the dose of glycopyrrolate is 0.1 milligram per kilogram. For most patients over 60 kilograms, it's safe to simply administer
2.5 milligrams
of neostigmine and 0.6 milligrams of glycopyrrolate, and then to monitor the recovery or the reversal on a nerve stimulator. These drugs do not work instantaneously, and they take 5 to 8 minutes to have their full effect on muscle recovery. Right, so now we've covered muscle relaxant dosing, We've covered the duration to onset of action. We've covered the duration to the onset of recovery or reversibility. We've covered how to safely reverse these drugs and how to monitor that reversal with a nerve stimulator. And we've covered how to manage inadequate reversal. Let's now look at some drugs in more detail. So firstly, let's look at succinylcholine, which is also called scoline, and it's also referred to as Sux. So this is an excellent muscle paralyzing drug, and I've used it hundreds of times. As I said earlier, the dose is 1 milligram per kilogram total body weight. Its onset is fast. We see fasciculations at about 45 seconds, and that's when we know that we can proceed to laryngoscopy and intubation. Its duration of action is anything from 5 to 11 minutes, which seems a little unpredictable actually, and it's not the classic fast on-off as you would think. Being paralyzed or apneic for 11 minutes in a can't intubate, can't ventilate scenario is a long time, and so the reality is that the classic teaching that this is the drug to use in difficult airway scenarios because it will wear off quickly and the patient will start breathing spontaneously again isn't actually that reliable. This drug will still keep you paralyzed for a long period of time, and especially if you overdose. So if you have someone that's 60 kilograms and you give the whole ampule of 100 milligrams, that patient is going to be paralyzed much longer than their time to desaturation and hypoxic cardiac arrest. There are multiple problems with scoline. It causes bradycardia. It can cause bronchospasm. It has a relatively high incidence of anaphylaxis. Patients complain of muscle pain post-operatively because of the fasciculations. It can cause hyperkalemia. The standard rise in potassium level when we give scoline is about 0.5 millimoles per liter. But in certain high-risk patients, it can raise the potassium by 3 or 5 millimoles per liter. And those are classically patients with neurological disorders. It can cause scoline apnea, which is in patients that have got low levels of acetylcholinesterase or abnormal acetylcholinesterase. They can't metabolize the scoline as quickly as normal, and they have prolonged apnea from the scoline, and they require prolonged ventilation post-operatively until the scoline wears off. It can cause a phase 2 block, which is basically a block that looks like a non-depolarizing muscle relaxant block. That is that it has fade on the train of 4 count, and it can last for a variable length of time. And there's no reversal possible for this. One has to just keep the patient under anesthesia and ventilated until the phase 2 block wears off. So just to recap on the hyperkalemia from scoline, because it's a major concern in a number of patients and you don't want to make this mistake in your clinical practice. As I've said, potassium levels normally rise by about 0.5 millimoles per liter after a dose of scoline. And so we want to avoid scoline if the potassium level is greater than 5 millimoles per liter to start with. In certain disease states, the rise is significantly more. And I've heard of rises of 4 or 5 millimoles per liter from some of my colleagues that have been involved in cases where scoline has been given and the patient has had a hyperkalemic cardiac arrest, and then on the blood gas during that arrest, they see potassium levels of 9 or 10 millimoles per liter. So examples of where we want to avoid scoline are trauma cases with severe muscle damage, burns patients after 12 hours, critically ill patients that are in the ICU, patients with spinal cord injuries with monoplegia, paraplegia, or quadriplegia, and then any diseases of the muscle. The other topical problem with scoline is scoline apnea. I've never been involved in a case personally, although a close friend of mine has had to manage a scoline apnea patient recently who went through to the ICU for prolonged ventilation after a case. And as I've said, this is due to an absolute deficiency of pseudocholinesterase or an abnormal pseudocholinesterase that metabolizes scoline in the plasma. It can be an acquired problem, which is in certain illnesses and drugs, of which there is an extensive list. Here we see prolonged duration of action, but it's not too excessive. Or it can be inherited, where there are multiple different types of pseudocholinesterase, and this can result in prolongation of the block from 40 minutes to up to 6 hours after the initial dose. The treatment is ventilation with sedation, either in theatre or in an ICU setting, until the trainer-4 ratio reflects full reversal. The use of plasma to replace pseudocholinesterase levels in the body is no longer advised because no one knows the exact dose that is needed, and giving the patient plasma for this actually has the potential for more harm rather than just keeping them safely ventilated and asleep in theatre or ICU. A phase 2 block is more likely to occur with overdose of your initial SUX dosing or with repeat dosing. And like I've said, in this situation, the SUX behaves like a non-depolarizing muscle relaxant, with a trainer-4 displaying fade. However, reversal drugs won't work, and we simply have to wait for a trainer-4 count of 4 out of 4 with a ratio of more than 90% before extubation.
Let's now discuss rocuronium, which is my muscle relaxant of choice. The standard intubating dose, as listed in most textbooks, is 0.6 milligrams per kilogram, ideal body weight. As I've said before, I seldom calculate the ideal body weight. I rather have a look at the general physique of the patient and then decide on what an appropriate dose of rocuronium will be for them. The onset of action at a dose of 0.6 milligrams per kilogram is normally around 90 seconds, and its duration of action is around 35 minutes to reversibility. In my clinical practice, when I'm needing to intubate and ventilate patients that are having shorter surgical procedures, I frequently underdose the rocuronium, and I often give doses as low as 0.3 milligrams per kilogram, ideal body weight. And this is one of the advantages of rocuronium. Because of its relatively fast onset time, one can give a lower dose than usual and just wait a little bit longer before intubating the patient, or one can use other drugs to blunt the intubation responses and allow earlier intubation of the patient too. And this would include drugs like a higher dose of propofol, magnesium sulfate, lignocaine, or synthetic opioids to facilitate intubation. And then we will still have a patient that is paralyzed for the surgery, intubated and ventilated, but the muscle paralysis will last possibly only 20 to 25 minutes. So rocuronium has the advantage of being able to be given in lower doses. We can give it in the standard intubating dose that I've gone through previously, and then we can also use rocuronium for rapid sequence intubations, where we give
a higher dose of 0.9 to 1.2 milligrams per kilogram based on the ideal weight of the patient. And here the duration of action is about 90 minutes. There are still some problems with this drug. It does have one of the higher risks of anaphylaxis. It relies on hepatic and renal function for metabolism and clearance. Its stability is reliant on the pharmaceutical cold chain before it gets to you in theatre. And so it is possible to have vials that have poorly active rocuronium, and so you might find in those situations you need to use higher doses or more frequent dosing. Rocuronium also has the benefit of its unique reversal drug, which is sugammadex. Sugamidex is a donut-shaped drug that when we administer it intravenously into the blood or into the plasma, it binds the rocuronium within its donut shape, and it reverses the concentration gradient from the neuromuscular junction to the plasma. So rocuronium preferentially leaves the neuromuscular junction and enters the plasma, where it is bound to the Sugamidex in its donut shape. And so it results in rapid recovery from rocuronium paralysis. The donut-shaped Sugamidex and the rocuronium are then excreted in the kidneys, and the rate of excretion matches your glomerular filtration rate. So in an average healthy adult, the Sugamidex and rocuronium is going to be cleared from the plasma at about 120 mils per minute. So it is a fantastic drug to have available for the rapid reversal of rocuronium. Sugamidex has a few problems though. Firstly, it's expensive. Secondly, it can cause anaphylaxis. Thirdly, it can affect the oral contraceptive pill. So if you are administering it to female patients who are taking oral contraceptives, you need to advise them that they need to use a barrier method of contraception for a month after having received Sugamidex. And then the dosing range is variable depending on what dose of rocuronium you've given. And we don't need to get into those details now. Suffice it to say that you need to give enough Sugamidex so that the train of 4 count is 4 out of 4 and the train of 4 ratio is 90%. And then you know that you have given enough Sugamidex. So that brings us to the end of this video lecture on muscle relaxing drugs. I've really found it very useful to go through this information again for myself, and I hope that you found it beneficial too. And the take-home message is know your drug dosing and don't take any chances. Don't wake patients up when they're still partially paralyzed, because you can get into rather messy situations in the recovery room. And as always, we would really value your feedback, so please write to us via email. We would love to help more, and we would love to improve these talks based on your feedback. Take care.